I'm delighted to introduce our first speaker, Fiona Anderson. Fiona is a dispensing optician who is based in Inverary, which is way, way up at the top of Scotland, so she's come quite a long way to get here. And throughout her career, Fiona has continually challenged herself by gaining additional qualifications in business administration, refraction and ophthalmic manufacturing. And she's also authored and delivered numerous CPD articles and workshops in her native UK and also internationally. She's held several executive and non-executive positions in the optical sector, including being president of her professional association in the UK and president of the International Opticians Association. And she is currently the upper warden of the Worshipful Company of Spectacle Makers, the oldest optical charity in the world. And we are delighted, pleased, to welcome Fiona. So please welcome Fiona to the stage.
Thank you, Elaine, and thank you again to SILMO for having me here to speak. This morning I'm going to speak to you about looking at occupational solutions for our patients. So really from the teens all the way through to people my age and even maybe a little bit older. So this is what we're going to look at this morning, is looking at the complex visual needs that people have nowadays when working with multiple screens, how we can assess those needs and then advise on remedies for them. We also would be looking at the signs and symptoms presenting to us with regards to dry eye disease and other perhaps more holistic care of patients, and then obviously recommending some products which might help. So we'll have a look at the demographics that we're looking at, ergonomics, which plays a big part of things, looking at digital eye strain and computer vision syndrome, visual task analysis, which again is very important to be able to assess the needs and then accurately recommend. We'll look at some low add boost lenses, some digressive lenses, some occupational lenses, some full-blown progressive lenses, and then hopefully I'll give you some take-home points that might help for your practice. So technology and systems of everything have really evolved over the last numerous years. Nowadays, it's not just people who are perhaps in their teens and 20s that use computers. Computers are used all over, even preschoolers would be using computers. And as we see in the picture there, we have quite a small child using a computer. And again, since COVID, of course, many more things have gone online, and we have done lots of things via Zoom and Teams and various other things. And again, many of us are not using just one screen, but we're using multiple screens. We may have a smartphone, we may have a tablet, we may have a laptop, we may have a desktop. And again, depending on people's occupations, they may even have numerous screens. Think of someone who's working in a control room. They could have a whole bank of screens that they have to look at. And probably about 70% of people are using more than one digital device at a time. A recent study found that 90% of people use digital devices for more than 2 hours a day, which to me is quite staggering. And about 60% of people use them more than 5 hours a day. So we're using more and more digital devices. And again, it's not just the young people, it's the older people as well. The silver surfers, those people with hair colour like mine, or perhaps no hair at all. And they're using computers many more hours than they used to. There was a recent study in the UK on screen time that the government commissioned, and it was around the sort of impact on well-being and education. And there was an increase found of about 50% in the increase in use of digital devices by children and young people, which actually constituted what they called a behavioural addiction. So these people could not actually function without being attached to some sort of device, whether it was a smartphone or a tablet or some sort of gaming device, perhaps like a Nintendo Switch or something like that. And again, we see this more and more. You only have to commute on public transport and you see people literally not looking at anyone else, but literally looking, 10 centimetres away from their nose, which, as we all know as opticians, is really not good for your accommodation system. You would really want to hold things slightly further back. So looking at that study and another study which was published in the British Medical Journal, which was a 2025 study by Zhu Dongfeng et al. And again, I do have some references at the end. There was a meta-analysis done on dry eye disease as well. And again, when you think about it, if you're sitting looking at a digital device all day, I know if you're anything like me, if you're concentrating, your eyes are wide open, you're concentrating, and of course your eyes get dry. We forget to blink, and the whole system all sort of locks up. And again, post-COVID-19, we've all spent so much more time indoors, in my part of the world, in a heated environment, because we're further north in latitude than Moscow, it's very, very cold. Or further south, perhaps here in Paris, it might be air conditioning. So that environmental areas that we're in also can have an impact on what we do. But we'll look at dry eye disease a little bit further on. But the net result in all of this is visual stress on our visual system. So again, looking at the pictures, how many of you sit like the guy on the left-hand side of the screen? We sit on computers all day, we start out all nice and straight, and by the end of the day, we're tired, we slump forward. It's really not good for your posture, for your back, and other things. Again, in the UK, we have a National Health Service that looks after the health of the whole body, not just eyes, and in Scotland that is devolved. And if you go onto the NHS website, you can get lots of information on different conditions. And one that's become more prevalent, which I was actually quite surprised about, is there is actually a condition called text neck. Okay, so think about that, text neck, and I'm going to do a demonstration. If you see people looking at their mobile phones, they don't sit like this, do they? They tend to have their heads further forward. Now again, the human head weighs about 7 kilos. But the weight that you put on your spine, when you incline to 15 degrees, it increases to 20 kilos. So think about that on your vertebrae. It's not good. It can cause problems in later life. And again, we all know, our posture, we want to be as upright and as straight as we can. These seats are not wonderful for it because there are no backs on them. Everyone's leaning forward. So again, I can see you all now sitting straighter in your seats. But again, your workstation, wherever you use your computer, is really important. You would want the top of your screen to be somewhere around where your chin is, so that again, if you're using some sort of degressive or progressive lens, you can get into the right part of the lens to see it. And again, sitting on it, I examine for my professional body in the UK, and we often hear students saying to us that when we're using a screen, we should adopt the 20-20-20 rule. So for every 20 minutes, we should look 20 seconds at an object 20 meters away. I always ask them, how many people do you know that do that? Because I know I certainly don't. I may get up after 2 hours and stretch my back and go and make a coffee. but it's really not something that people would do regularly. So again, some of the things that patients might come in and report to you are things like, not just eye fatigue or dry eye, but it could be headache, it could be neck or shoulder pain, it could be lower back pain, it could even be pain in the legs, because again, if the posture's all out, it transfers the whole way down the system. So again, you might not think someone coming in saying that they've got sore legs is actually got anything to do with them looking at a computer screen, but it might actually have that. So again, this is where this whole holistic looking after patients and listening to what they say is really, really important. So again, we've touched on digital eye strain, visual fatigue, and other things like that, dry eye. So dry eye, as we've already said, is really common in most patients. Again, for women of a certain age, to do with their hormones, it can be attached to that as well. And again, we've already said that it's much more prevalent since COVID-19. And again, you only need to go to any pharmacy or even a supermarket and look at the dry eye preparations that are available, and there are hundreds to choose from. So you can use lots of different ones there. And again, I'm sure there'll be lots of people in the exhibition halls with lots of different samples that you could perhaps try if you're looking to do more in dry eye in your practice. Again, lots of the things that we should be perhaps talking to our patients about is what is the discomfort that they're experiencing? Is it dry eye symptoms? Is it skeletal? What is it? Do they have a headache? Again, lots of headaches are not actually attributed to sitting at the screen, but they might actually be dehydrated. Because again, if you're concentrating on something, you might forget to go and have a drink. I'm a big coffee fan and I tend to drink way too much coffee. But every coffee I have, if I'm working at home, I try to also have a glass of water with it as well, just to keep the hydration levels up. Again, it could be itching of the eyes, it could be sort of asthenopia type symptoms that they have. It might be intermittent blurred vision, which again is something that we don't really think about, but with dry eye, you can actually be knocked back a couple of lines on the chart just purely because of your dry eye. I didn't believe it myself until I experienced it, and then I thought, oh well, okay, use the drops, use the drops, use the drops, and use them all the time and use them more often. And again, we've already sort of touched on your workstation setup. You want to have that as good as you possibly can. So what I do in practice, and I'm not saying that you need to adopt the same sort of process, but what I find is I actually have a printed out sheet which is laminated, which I can just go through a series of questions with patients and ask them some of these questions as to so that I can uncover their needs. So what are they doing? What's the size of the font? What's the colour of the computer program? I had one lady who had a massive problem because it was blue print on a yellow background and she didn't have the contrast. So literally they went back to the software developers and asked them could they make it black on white, and it made her life so much easier. Are they sitting at a desk all day, or are they in an office whereby they're running around and doing different things? Are they on a reception desk? Are they up? Are they down? Are they moving around? That can have a play on what type of lens you would perhaps advise them to have. What's the position of them? You know, lots of people now use standing desks, which obviously your position is going to be different to what it would be if you're sitting down. Some people use a bit of both. I have one colleague who uses a standing desk all the time. And again, what sort of tasks are they performing? Is it all the time? Is it only sometimes? So again, these are all things that you would need to take into account when you would be recommending a solution for them. What's the lighting like? Are they sitting with their back to the window? That's a big one. You'll get a lot of glare on that. So again, your screen is not going to perform to its best if you've got a whole load of light coming in. So it might just be a case of repositioning the screen, or perhaps having a blind fitted on the window. Contrast, we've already said about that yellow and blue and black and white. Can it be changed? Some programs can't be changed, but again, it's always worth speaking to your software developers to see if they can. And again, think about colour matching. If you've got someone with a job that colour and tone is very important, so again, people that I have had to try and help in practice have been not only people who are artists, but one of the most difficult patients I had was a dentist. And he was doing a lot of cosmetic dentistry, and he was matching colours for implant lenses, for veneers, and he had a blue attenuating coating, and it actually changed the colour of what he was looking at. So again, that's something to think about, that what you recommend, is it actually going to change things? And again, of course, working distances, as opticians, that's very important, isn't it? If someone's working at 15 centimetres, 30, 45, 60, or it could have been all of those distances at the one time. And again, what's important is, are there any hazards in the workplace? If you give someone an intermediate single vision pair of lenses, yes, the computer screen is great. They get up to go and make a cup of coffee. Are they going to trip over something and fall? So again, these are all things that you have to think about. Bear all these things in the back of your mind. Now, as I say, I'm not suggesting that you follow this to the letter, but it's something that I have found very helpful in practice. So let's think about different lenses that we might be offering to patients. So the first one, we'll start with the young people, the teenagers and the early 20-somethings, and think about low-ad boost lenses. So these are the lenses that you think are perhaps just give you a little bit of a boost. So the basically are a single vision lens with a little bit of an ad. I remember when I was pre-presbyopic, I thought, oh, I'll get one of those low ad boost lenses. And then when I had my refraction, my ad was 125, so that didn't work. So again, often, depending on the manufacturer, it might be a 0.4 ad, it might be a 0.6, a 0.8, even maybe up to over a 1.2 sometimes. But again, those lenses are specifically made to give people that extra little bit of boost close up. There will be hundreds of lens manufacturers here in the hall. So again, if it's something that you're not already using and you'd like to find out more, go and have a chat to some of your manufacturers. Again, some of them, this slide is quite good, the one that says dispenser guide, okay? Dispenser is a word I'm not overly keen on, because I think, is it a paper towel dispenser, a soap dispenser? But we're thinking of the patient who is dispensing the lens, okay? But as I say, it's not a word I'm particularly fond of. But again, these lenses can be very helpful to patients. Moving on, again, a degressive lens is something that might be helpful for patients. Again, it's something that we would order with the reading prescription, and then it would degress slightly as we come up the lens to make sure that we've got a bit of a range where we can see things, computer screen and close up. Now, I have a pair of these, I call them my computer glasses, and they literally sit by the computer. I put them on if I'm sitting there. I have about a 21 inch, which would be 30 some centimetres. Quite well, bigger than that. 21 inches would be 40 some centimetres, quite a wide screen. And if I'm sitting writing content, I have them on because the whole top of the lens is computer, and then I've got a little bit of near if I need to look at notes or anything else. And again, I find even with a full-blown occupational, I still have to take my head back a little bit. So these ones, because they're computer distance and then close up, I can sit quite comfortably at the screen and I don't have to move my head, which is great if I'm sitting there all day. A lot of people do have these lenses, and often they're dispensed as a second pair. So it might be your lab or your lens company might have an offer. It might be first pair is full price, second pair is half price, or sometimes even free, depending on what the lens is. So again, speak to your lens manufacturers and see what they can offer, because I find as a progressive lens wearer, they're great for most things, but they're not brilliant for some things. So I prefer to have specific lenses for other things. And again, it can often be an additional purchase for patients. So again, that's a great practice builder. That will bring in more revenue to your practice and make you hopefully a little bit more profitable. The one caveat with these lenses would of course be is that they are literally for close work. So patients should always be advised not to walk around in them and certainly not to drive in them. And again, these lenses have been on the go for quite a long time, so they are available from most companies. They'll all have some offering, so please go and speak to them and ask what they can offer. Again, as an examiner for my professional body, the difference between a digressive lens and an occupational lens is not universally understood. Lots of people will talk about an occupational lens when they actually mean a digressive lens, and vice versa. And the two terms are really not interchangeable. I would say a digressive lens is more a static lens. That's a lens that you would use for prolonged periods in front of the computer, whereas an occupational lens gives you a little bit more scope. So it's, to all intents and purposes, it is a progressive lens, but again, you might have a little bit extra that gives you more range for close-up. So when I'm in practice and I'm actually doing my day job and not writing content and things like that, when I'm actually in practice seeing patients, I wear an occupational. And I have two different ones. I have a 2 meter restricted distance lens and a 4 meter restricted distance lens. And I'll explain the differences between them. So the 2 meter one gives me 2 meters of clear vision, which is fine if I'm in a small practice, but it also gives me a slightly wider area for intermediate and quite a good area for reading. The 4 meter one I would tend to use if I was in a bigger practice, or if I was in a practice that had multiple consulting rooms and I was running around a little bit more. So again, 4 meters is clear, and then again, intermediate and close up. So the bias is slightly different on that lens depending on which you do. Some companies do 6 meter. Again, to me, a 6 meter would be more the sort of testing distance, so you would be thinking, well, that's probably more of a normal progressive lens. But again, a 4, 3, 2 is often quite a usual offering from most of the lens companies. Again, lots of people don't really see the difference, and I must admit, with my 4 meter ones, I have jumped into the car and gone out and seen patients in nursing homes and things like that, and it's only been when I've looked in the rear view mirror I thought, oh, I've got the wrong specs on. But again, even with those specs, which are a 4 meter restricted distance, my vision is probably about 6/9 Snelling. So I'm okay still to drive. However, I see much better with my full-blown progressives on. But again, we would be thinking of these more as an indoor lens. So again, patients should always be advised not to drive in them. And again, a lot of patients might have these in addition to their full-blown progressive lenses. And again, I'm probably preaching to the converted in France, where multiple pairs of spectacles is almost the norm. In the United Kingdom, it's not so much. It's a much harder sell, if we want to use that term, to get people to buy spectacle lenses for different things. Even getting people to buy a prescription sun spec, is difficult in the UK. Sometimes they're still looking for ones that clip over their regular specs. Whereas I would always advocate, it's a bit like the shampoo and conditioner. they're not as good as having two separate ones. When you have these combined ones, it's never really as good. So we all know about progressive power lenses. We've all been dispensing them for a very, very long time. Obviously, as time has gone on and technology has improved, we've had many, many more offerings for patients. Again, we can offer different manufacturers. We'll have different types of lenses. We'll have some which will have different biases as to whether you're driving in them or spending more time at the computer. And again, the advent of freeform tooling and surfacing has basically just exploded the offering. Again, we have a book that I use in the UK. It's available via my professional association as part of our membership. And all the lens companies update that and keep it up to date every time there's a new lens comes on the market. I have a printed copy of the last printed copy, which goes back to 2018, I think. And at that time, there was 1,438 progressive lenses. I dread to think what there are now. There'll be many, many more than that. And again, they will all come predominantly now from a single vision lens, and freeform technology will take over and surface that lens into a progressive. Some will be front surface, some will be back surface, some will be dual surface, and on we go. As technology has changed and improved, what we're able to offer patients is much, much better. Again, we can do different manufacturers' lenses, which will have different kit that come with it to enable us to then even more tailor make that lens for patients. So whether it's something that's attached to an iPad, or whether it's one of these tower things, or whether it's a 360 arc that goes right round and takes photographs and sorts everything out. There is a whole range of things. And I often think, again, in the United Kingdom, we work very much with optometrists who give us not only the prescription, but look after the health of the eyes. The model is different to what it is here in France, where you have refracting opticians and predominantly ophthalmologists who look after the health. But again, we get that prescription, don't we? And whether it's the doctor's office or the optometrist's office, they have an OCT, they have a fancy automated phoropter, and they've got all this kit. And then we come out with a ruler and we take the measurements and we charge that person €1,000 for the pleasure of having that pair of specs. And their eye examination is maybe €200. So where's the value in bringing that out? So if you've got kit, use it to add to the theatre of what you're doing and make that person feel that they've really got value for money in that premium product that they're buying. Again, there will be loads of kit here. So go and have a look, chat to the people on the stands, ask if you can try it. Again, now when we're doing refractions, if we're using a phoropter, it will basically translate that into the prescription. It will go directly to the lab, and it's all out there in the ether now. Gone are the days of writing things down on an order pad. So let's think a little bit more about this dry eye disease that I was talking about, and I'm not by any stretch of the imagination an expert on this. But again, I've been in practice for a long time, and it's often, as an optician, I'm the person who's front of house. It's often me who's fielding the questions from patients and trying to help them as much as possible. So of course we've got all the over-the-counter things that you can just use as much or as little as you feel you need them, and that will help just moisturise and soothe dry eyes. Again, if you've got severe dry eye, you might actually your optometrist or ophthalmologist might suggest that you use a gel in the evening, something that's a bit more viscous and doesn't evaporate off. They last better and sometimes can be used in conjunction with the drops for during the day. Again, just something like a warm compress, that might help. I'm very guilty of telling patients to do it but not doing it myself. I do have one of these bags that goes in the microwave, and then you put it on and you lie back for 10 minutes, and invariably I fall asleep. But the whole point of doing that hot compress is to then massage the lids and actually loosen up some of the gunk that might be there. And cleaning your eyes carefully with lid wipes or some of the sort of aerosol soaps can be helpful as well. You would think that perhaps taking debris away would actually be worse for dry eye, but it's actually better. Good ocular health just promotes better quality tears. You might actually have to have a prescription medication from a doctor or from an ophthalmologist, and again, it kind of really depends on what type of dry eye you've got, whether you're not producing enough tears or whether the tears you're producing is of a poor quality and they're evaporating away. So again, there are lots of things available, and I wouldn't purport to know what they are. I don't prescribe. Sometimes just lifestyle adjustments are enough. So again, taking that glass of water, having a glass of water just sitting in a room, where you can actually have a bit more moisture in the air can be helpful. Those regular breaks that none of us actually take just promote better eye health. And again, things like getting enough sleep, eating appropriately, your dark green leafy vegetables we all know about for AMD, but things like oily fish, again, help improve the quality of our tears. And again, make sure that your computer screen is at the correct height. If you wear contact lenses, again, perhaps consider taking them out when you come home from work, putting on your spectacles and giving your eyes a little bit of a rest. There are also specialised procedures that you might have to think about if you have severe dry eye, so something like perhaps punctal plugs, or lots of practices are actually offering dry eye clinics now where they're using like IPL, intense pulse light treatments, which help, or some of the lippy flow type things, some of the eyelid cleaning devices, and lots of other things. As I say, I am by no means an expert, but again, I'm sure there will be loads of people here today who are. And again, you might also consider taking a nutritional supplement as well, so that again, there are lots of different things on the market available that might actually improve the quality of your tear film and perhaps stop it evaporating off. I have even heard of some practices who, in conjunction with other healthcare professionals, have been offering acupuncture, which also can help. The acupuncture points can actually stimulate tear production and reduce inflammation in the whole visual system. So again, not something I've tried, but again, something I've actually heard about. The next slide I have are some references, which please feel free to take a copy of that, take a picture of it if you want. But it's where I used some of the websites to get the information for this presentation. And again, there are probably some websites that you may actually find useful if you have time to go and have a look yourself. So I'll leave that there just for a moment till everybody who wants to gets a picture of it. Right, looks like everyone's got that. So really, in conclusion, nothing to do, of course, with dry eye disease or lenses, but just some nice pictures of lots of SILMO around the world. The one on the left is SILMO Prague, which we were in May, I think, of this year. The middle picture actually isn't a SILMO picture. I literally bumped into Amelie at 100% Optical in London when we were coming out of the coffee shop. And then the one on the left is SILMO Singapore, which was taken a couple of years ago with colleagues from there. So again, I just thought that was maybe a nice way to finish. But in conclusion, let me say that all of these lens options, whether they are progressive lenses, low ad boost, occupationals, digressives, all have their place in modern day spectacle dispensing. And I think the days of us giving patients a one-size-fits-all are gone. I have at least 30 pairs of specs. Most of them are progressives, but I've got sun specs, I've got clear specs, I've got progressives, I've got degressives, I've got occupationals, I've got, you name it, I've got it. Different colours to wear with different tops and dresses, and ones for posh and ones for during the day and ones for going to the supermarket and various things. Every single patient is an individual, and their needs need to be taken specific to them. It's not like going into some of the stores, Samaritan or Printemps or whatever, and trying something on and seeing if it fits. We are the professionals. We make things fit. We help with the choice of lens. We help with the frame. Really, if your specs are good, you should put them on and forget that they're there. You should be able to see well and feel great. But everyone has a specific need, and that's where our job starts, is listening to that patient, taking the information, and treating every single patient as an individual. And we will hear more about that in the next talk, so hold that thought. Again, dry eye disease is something that may not seem front of house when patients come in. They might not even be aware that they have dry eye disease. But I would say more than half of the patients I see, and they're not all oldies like me, even young people have it. Again, particularly females in with the hormone cycle and things like that, definitely makes dry eye something that we should be thinking about. And again, speak to whoever's doing your refraction, whether it's an optician or an ophthalmologist. You might not be able to improve the vision with a pair of specs, but it might just be that they need a dry eye preparation in addition to that. So again, that's where I keep coming back to this whole sort of holistic care of the patient and everything that we should be doing. And as I say, the dry eye thing is massive, and I've only touched on a very, very small part of it. So thank you for your attention. I'm very happy to take some questions if anyone has. We do have our interpreter here, and my colleague Elaine is completely fluent in both English and French. So we can have some questions if anyone has any. And if not, please don't feel you have to. Enjoy the rest of your day at SILMO, and thank you for being here. Yeah.
I will try to do it in English. Thank you for sharing your thoughts and expertise. I really appreciate the clarity of your speech, so thank you for that. And I have a tricky question. To be honest, I don't know if I'm the only one in this situation, but often, I have people saying, okay, why do I need other pair of glasses in addition to my progressive lenses, where I see a lot of advertising saying that now progressive lenses are the solution to see clear at all distances, in all situations. So I don't know if you have any golden word to share with us.
So let's see. Absolutely, I would say that that is a big thing, because of course all the marketing for progressive lenses is these are the only pair of spectacles that you're ever going to need. You're going to see distance, intermediate and close up. What I say to patients is it might not translate terribly well, but I live in a very rural area where we have farming and things like that, and I always say to people, you wouldn't wear your Wellington boots on the dance floor, would you? So that starts the conversation, and it's something specific. Again, EC directive is that if you're on a computer for more than 4 hours a week, your company must pay for you to have your eyes examined, and if you wear spectacles for the screen only, in 40 years in optics, I have dispensed 2 pair of spectacles for the screen only, because most people need them for other things. But they have to help you with either giving you something that you can use or a contribution towards something. So again, you can perhaps say it's almost the tools of your trade. So it's something you need to do your work better or perform better or something like that, or a sports pair or whatever. So again, it's just finding that niche that you can, there's a bit of psychology in it as well. You know, we have to be all things to all people, don't we? We have to have our spider senses going and pick up on all these sometimes very subtle hints that patients give us. But yeah, it's a really difficult one, and ultimately it comes down to money. You know, so it is difficult, and you know, people will say spectacle lenses are expensive. Ask them, do they go to Starbucks every day and buy a coffee? Because if they stopped buying their coffee, if they made it at home and took it in a cup, they could soon afford that second pair of specs. So again, as I say, it's a bit of psychology, it's a bit of science to do that. But yeah, again, I have the luxury of one, having been a practice owner, so if they don't come back, it's my loss. I now locum, so I don't really work anywhere for more than a couple of days at a time. And again, you can be a little bit more off the cuff with people in that situation. But again, still being respectful because you're a professional. But there are ways round about it. But again, you've got to just sum them up and see what you can do.
Thank you.
Merci pour cette belle conférence. Pour éviter la fatigue oculaire numérique, quelle est la durée minimale qu'on va utiliser être devant un écran pour éviter ou pour réduire au maximum? Parce qu'on a des patients qui travaillent dans les assurances ou dans les banques qui sont à longueur de journée sur un écran, sur une tablette. Et aujourd'hui, les enfants aussi utilisent les tablettes. Donc, quel est le temps minimum qu'on peut conseiller, même si on leur donne des verres anti-fatigue? Mais il y a un temps qu'on peut conseiller et recommander. Voilà, merci.
Okay. Thank you for that. Yeah, I mean, I would go back to that 20-20-20 rule. So for every 20, so it's not even in an hour, it's every 20 minutes. Just look up from the screen, look in the distance, take that break. I would say 2 hours in front of a screen is more than enough time. Certainly for me, I feel my posture goes, I need to stand up, stretch, you know, round my shoulders. But that would be the one. It's really difficult because again, you get involved in things and you concentrate and, oh, just let me finish this bit before I do any more. And often if it's your job, you may have a manager standing over you, making sure you do your job. But yeah, again, probably the European Working Directive, there would be some guidance in that as well, I would think, as to what the appropriate time would be without a break. But again, all the other things, the environmental, you know, a humid environment, drinking lots of water, will all help.
There's no more questions. Thank you, Fiona. That was a very enlightening talk. Thank you.